All right. Hello everybody. Welcome to the next session of Virtual Global Spine. Today, or rather tonight, I'm going to be presenting an interesting topic, a little bit different from what we normally talk about. This one's going to be about managing some of the unmanageable disasters in spinal surgery and some of the complications that we all dread and all fear and never want to ever happen. But these are all things that can potentially happen during surgery, and it's good to be calm, be alert, and be aware uh, when and if these complications ever happen, and just know how to manage them. Because a lot of these things I'm going to talk about, uh, you can be controlled in a certain way, no matter how bad it may seem. So, um, just the other way to think about this talk is what to do when things go horribly wrong. That's probably what I should have put over there. So, we do our best in every single surgery. But despite our best intents and the best planning and best organization prior to surgery, complications occur. If there's a risk of, let's say, 1% complication, that means it will happen one time out of every 100 patients you operate on, right? So the busier you are, the busier you get. There's just some chance, just if you're going to play statistical odds, that this something might happen, right? Maybe it doesn't happen, but the more outpatients you operate on, that number potentially gets a little bit higher over time. So broadly categorized, um, complications can occur in any sort of a way. It could be anesthetic complications. They could be surgical complications, such as you get a duotomy or potentially do the wrong level. And a lot of these things are avoidable in many ways. Hence, why there is this emphasis and attention to speaking with your anesthetist, speaking with the surgical team, make sure everyone's on the same page, everyone's on board. The surgeon is driving the ship. You're the captain, and you have to make sure all the people in the room kind of know what you're doing, what step you're at, and if God forbid if something happens, what steps they can do and what steps you can do to try to fix problems that may happen. So just jumping right into it. So this is a patient who we operated on during my fellowship. A 62-year-old lady who had pretty significant cardiac disease. She had coronary artery disease. Was on aspirin and Plavix. She had multiple different medical comorbidities. She had pretty severe osteoporosis and renal osteodystrophy, as you can see. And she had developed a severe thoracolumbar spinal deformity, as you can see. With positive sagittal balance, and she was doing very, very poorly. She had very significant pain and a poor quality of life. So, um, with that being said, there was extensive discussions with the attending and the patient. She had gone an exhaustive pre-medical optimization. A lot of that, a lot of these things are, again, this is done on an elective basis. It's not an emergency. So when that's the case, then you have time to plan for certain things. And this is one of the kind of the beauties of spinal deformity in a way, is that you can, it's very rare that these surgeries are an emergency. You often have time to plan in advance and get all your ducks in a row before you go ahead for the day of surgery. So some of the things that can be done for this patient before you bring them into the OR, just these little things that you can do makes such a big difference on the day of surgery. So I really, really harp on and I really stress the importance of preoperative optimization for these patients prior to going to surgery. Now, realistically, can you wait 3, 4, 5, 6 months before the patient gets surgery? Not really. Patients have choices. They may get frustrated with you. They may go somewhere else. They may not want to do it, right? They may not be compliant with the protocols they have in plan for them, right? But you try your best, and you try to get things, as many of these random variables under your control. So some of the things that we did, obviously hold the aspirin and Plavix, hold your antiplatelets, usually for about 7 days. Anticoagulants for a couple of days before surgery. And it depends. If the patient has a mechanical heart valve, you may not be able to hold it for that much longer, right? The longer you can hold it, the better, theoretically. If the patient, for this patient, chronic renal disease, or sometimes patients have religious reasons why they cannot receive a blood transfusion during surgery. These are things you may want to consider. We use Cell Saver during surgery, which basically collects the patient's own hemoglobin and centrifuges it, concentrates and give it back. But that it's not the greatest. I mean, it does the blood they give back has the oxygen the oxygen carrying capacities of normal blood, but it often lacks um, the platelets and the blood factors, the clotting factors that are found in whole blood. So it's like you're giving back oxygen, but you're not really giving back the elements that help the blood clot. So it's tricky and it's very expensive. So, it's not, you can't really use it on, every single case. We typically do use it for our deformity cases. Um, uh, some considerations, we try to get this patient on epogen, which is erythropoietin, which basically helps them generate their own blood before surgery. Another thing you can potentially do is have them donate their own blood for patients who are religious and store it, and then you can potentially transfuse it back to them during the day of surgery. We had cardiac consultation. These are basically, I don't want to harp on every little thing here, but basically this patient underwent an exhaustive cardiac and pre-medical optimization. Another thing is treatment of the osteoporosis. Um, is to start this patient on, we started this patient on Forteo or teriparatide. The only issue with this is that it can take months and months for them to get any sort of improvement, and it doesn't really show up on a DEXA scan for quite some time, the improvement that they got. So if you get let's say a preoperative DEXA and it shows osteoporosis, and you start them on Forteo, and you get another, let's say for 6 months, and you get another DEXA scan, that may not show much of a difference. So you can't really, it's hard to like gauge what your improvement was, but they do better with this. And then other intraoperative adjuncts are basically things to stop bleeding. Like we use tranexamic acid very routinely. Um, as I mentioned, cell saver. Obviously these patients are going to get two large bore IVs, potentially a central line, A line, so on and so forth. One thing we like is irrigating bipolar is from Medtronic called the Aquamantis. That tends to be very, very nice on soft tissue, very quick on getting hemostasis of soft tissue and stopping insensible blood loss during the surgery. So, all right, that's enough of that. But basically, what you can see is that there are a lot of little things that you can do before surgery to help the day of surgery go better. Okay. And it's these little things that you can do that can really make a huge difference. So it's just about planning in advance, talking your team, getting your ducks in a row before you actually do the case. So anyway, during the surgery, it was a very difficult exposure. She had multiple she had a prior laminectomy, non-instrumented, lots of scar tissue, huge incision, bleeding, 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 blood pressure hard to control, all over the place, very difficult to get blood loss, right? And while this was happening, the patient became slightly hypotensive. We tried to give some pressors, some more fluids, and it all of a sudden went into cardiac arrest. Prone, big incision open. And can you imagine that? Now that's like the worst possible thing that can ever happen. So what do you do? All right. Well, if you're in a place, remember you have a patient who's prone on a Jackson table, potentially in Gardner-Wells tongs, big, big, big incision from T2 to pelvis, open up, and the patient is going to cardiac arrest. The first thing that needs to be done, obviously, is cardiac resuscitation. And that basically involves doing chest compressions, right? But how are you going to do that with the patient prone with a big incision open like this, right? So, and then remember that they bring a stretcher in. You can't just flip the patient and fall on the floor, right? You have to close the wound. I mean, these are all kind of, maybe it's not, dura's open, in that case, we didn't have that, but you can have implants that are open. It's like, this is like a disaster. This is an absolute catastrophe in many ways. So what do you do in this case? All right, well, you can do prone CPR. So when flipping a patient is just not feasible, it's just going to take too long. Remember, the most important thing when a patient has cardiac arrest is to get the heart going again. And in that case, it often tends to be high quality chest compressions. So in this case, closed CPR is possible. Basically, if the patient's on a Jackson table, and this is what we had to do, the patient's on a Jackson table with the chest pad, you can start pushing down on the scapula of the patient. It's obviously not the best way, but it's something that can get you by as these things are happening, meaning they're getting a stretcher in the room, somebody's closing the incision quickly, but you can, somebody in the surgical team so can start giving chest compressions. Now, if that doesn't work and the patient continues to deteriorate, then there are other things that can happen as well, and I'll talk about that. So the first thing that you have to do in the setting of cardiac arrest with a patient prone is just reverse CPR. If the sternal support is present, you can just do chest compressions, as I mentioned. You put both hands over each scapula. If it's not, for whatever reason, one member of the surgical team can essentially make a closed fist, put that under the manubrium, and another person can just start doing chest compressions or back compressions, really. This is obviously not easy to do if the patient has a large body habitus. Um, if they are, this is very, very difficult to do. This would be a very, very unique situation. But really, what the point of this is to kind of hold you by and tide you over until they can get all the necessary things. Ideally, they can give epinephrine, something to get the heart going, while the patient is prone. Okay. So it's just some maneuver to know about in the back of your head. Hopefully, you never, ever in your career ever have to do this. And then at the absolute last resort, this is not something that would be really feasible unless you had like a thoracic surgeon or somebody who knew how to do this come in. They can do open thoracotomy with the patient prone and do cardiac massage. Now, so the patient survives, and ultimately, not that admission, but ultimately later on, they ended up getting surgery. You can see that what was done. However, they presented back 3 months later with pretty significant PJK. Despite one of my favorite things to do is to use some sort of prophylaxis at the top of the construct. See this? Using a little bit of cement at the top of your UIV can help prevent PJF, meaning like pull out of the screws, migration of the screws, something terrible happening, but it does not necessarily prevent PJK. So this is one of the ultimate banes of our existence of a deformity surgeon is just proximal junctional problems. You're always going to face these in your practice, and they are frustrating, because when you get like your intraop X-ray looks beautiful, what a great correction. You get like the 6-week X-ray, it looks awesome, great, and you get that 3 month, oh, PJK'd already, right? So that's the unfortunate pain of being a deformity surgeon. But anyway, I just want to talk about this a little bit because it's such a common thing, and although it's not technically an intraoperative catastrophe, it's just such a common thing for us to deal with that it's worth mentioning here. And it's just such a common entity. There are technical definitions of PJK, which I didn't even know about. I had to look this up. I always just kind of look at it, I just kind of look at the image and, oh yeah, that's PJK, right? But it actually is like a definition for this. So more more of a radiographic diagnosis. However, it's really just a clinical diagnosis in conjunction with the radiographic findings, right? If a patient has the classic, pain at the upper portion of their construct, stooped posture, they feel like they're, back to where they were before surgery, they're claiming significant back pain. That's typically that's PJK. The X-ray just confirming what you probably already know. Now, I will say that I would much rather deal with a let's say a T9 PJK than a T3 PJK. If you go up to T4, let's say, an instrumentation is far more difficult to deal with. So I will say that I used to be much more aggressive, meaning I used to, I didn't want to have PJK at all as part of my practice. So I used to be more aggressive on going to T4, but nowadays I'm stopping more at T10, and then just letting them declare themselves. So I can always bring it up to T4. Now, PJK and PJF are kind of a spectrum. PJF is much more dangerous, much more severe, and usually presents as an emergency. This is when the screws migrate. There's a big, like I say, big herniated disc above the construct. And it can be due to complete disruption and failure of the posterior ligamentous complex. It's a very unstable, very dangerous situation. So these patients need to be kind of treated right away. And these patients have severe pain. They may have neurologic deficit. So it's not clear. PJK is more of a pain problem and a radiographic finding, versus PJF, which is more of a neurologic and more of a serious issue. It's more of an emergency. It needs to be kind of treated. PJK can kind of wait a little bit. Hopefully, you can brace them or something, get by. But when they PJF, it's kind of a disaster. So it's just really a spectrum. Now, there's basically different problems here that you can see, right? The middle being the PJ, the middle being your kind of your classic T9 PJK, where they have prominence and protuberance of the rods, significant back pain. Sometimes they present with wound problems, like the wound just pops open, or which was once well healed, now is like, the hardware rose to the skin, has some issue. That's your kind of your classic PJK. And then here is your high thoracic slash cervical PJK slash PJF, which is this is a disaster case, especially if they're rigid. This just gives me a heartache just looking at this. Um, with this is one of the hardest things for a spine surgeon to treat, your high thoracic PJK or PJF with this chin on chest deformity. Because here you're going to have to likely do a three-column osteotomy to pull this patient back up, bring him up to probably about C2. I mean, it's a nightmare. And it never is very satisfying in most of these cases. So these are very challenging cases. So I tend to like to deal with the middle one. If I'm gonna deal with the PJK, the middle one is like your classic, you just bring up the T4, they usually do great. Now, the vast majority of these, if they're going to happen, it's going to happen in about 3 months. That's usually the cutoff time. So when I get that 3 month X-ray, I'm just praying, praying, praying I don't see PJK because of 80% of the vast majority of these are going to happen in 3 months. And if they don't, they're usually most of the time they're going to be fine for at least 1 year. And then very rarely do they present with PJF. With the advent of prophylaxis, just cementing the screws, thoracic hooks, or tethers, these PJFs have gone steadily down. And I would even say that it's driven my own PJF rate almost to zero. Not PJK, but I've not seen PJFs nearly as much as when I use some sort of prophylaxis. My prophylaxis of choice is cement. I think just it's easy to put in. You don't have to really worry about it. Those transverse process hooks, those thoracic hooks are very futzy. They're difficult. They're very difficult to get in and line them up with a rod. I hate having to deal with that, especially at the end of the case. You just want to get out of there. So I don't usually do those. Tethers are very good as well. But I also find those to be kind of futzy and difficult to get secured. So I don't I just go with cement. Now,
Hey, JR, it's Mike. Can you hear me all
hey,
right?
how's it going?
Hey, good. Hey, good. Hey, I just wanted to look at those x-rays you showed of failure. Um,
Yeah,
I have all the same problems you do. And when I was younger, it was a bigger problem for me, I reckon. And I think you're right. As you learn a bit, you can move on. What I would do differently on all three of these cases is I would add more kyphotic rod bend at the top of every one of those constructs now. And I've certainly got X-rays that look like this as well. That looked awesome, at the first standing, and then after that, not so awesome. So, yeah, I mean, it's an issue for all of us. But just knowing what I know now, I would definitely bend those rods at the top a bit more. And I think one
yeah,
thing we underestimate is you want absolutely zero tension on the top of those the top implants.
yep,
If you're
yep,
finishing at
yep,
say 9, you want
yep,
no tension on those.
yep. Totally agree. I now just even just kind of cut the rod. I make sure it's almost flush. I don't even want to deal with that. And also, you're absolutely right. The tendency is that at the end of the UIV, the rod tends to be a little prominent. So you try to force that in there, or you try to cricket that in there, or try to with your inside two benders, try to hold it down. But you have so much force on those top screws. It's an absolute it's a very terrible situation, especially if you have these very strong, high diameter rods. You're putting a lot of force on that screw, so you're just kind of setting yourself up for some issues later on. Totally agree.
Yeah, thanks, man.
Um, I would say that I do it for essentially uniformly all my cases now, like having a soft landing. I use cement augmentation for pretty much all my cases as well. I remember when I was in fellowship towards the end of my residency, um, people were thinking about doing these like percutaneous screws at the top, but I found that not to be helpful and very difficult to get the rod in because you have a tower. It's so painful. I didn't like that at all. So I didn't see it helping at all. So I don't typically do that. All right, now let's keep moving. So we have a patient, 88-year-old lady, falls down the stairs. She has a pretty significant retroodontoid pannus, spinal cord compression, possibly some cord signal change, very tight at the atlanto-occipital junction, right? So And she also has an increase in her ADI. She has some evidence of degenerative instability of the atlantoaxial joint. So this was just something I showed. Oh, yeah, okay. So anyway, she was taken for a C12 posterior instrumentation infusion with a laminectomy. And yeah, this video is not showing, but during the placement of the right C2 pedicle screw, the patient jumped. And then after they ran a motor, and then there were no motors, right? So you had a situation where you had motors, and then instrumentation was placed, ran a motor. Oh my God, no motors, right? So what happened? What do we do? All right. So very likely now, unless there's something crazy happened where the leads fell off, something technical issue, right? Very likely there was an intraoperative spinal cord injury, right? So this tends, why I like to have this is that this is a classic on the boards that are coming up in October. I don't know if anyone here is taking their oral boards for neurosurgery, but this is something that is classically asked, the management of an intraoperative spinal cord injury. And I would say that how many times, it's rare that it's a true, I will kind of preface by saying it's rare that it's a true spinal cord injury. You always want to the first step, right? If you lose motors during a case, let's say you're working around the spinal cord and you lose motors after putting in instrumentation, right? The first step is always to undo what you just did, right? So if you were putting in a screw and you lost motors, take that screw out, right? If you were, I don't know, locking something and expanding you were expanding a corpectomy cage or something and you lost motors, undo that. Always undo the last move. Okay, that's the first step. Then always check for whether or not it's a technical issue, right? What's the blood pressure? Are you sure that the leads are in the right place? What's the patient's temperature? Um, these are all kind of things that you can kind of, is the patient, is there something going on with the patient? Are they hypotensive, right? These are all things that you can ask the uh, anesthesiologist and the neuromonitoring rep. Make sure, wait, don't start, doing things, just kind of wait, let the patient cool down, undo your last move, let them kind of figure it out. If there's a blood pressure issue, let them give some pressors, get the blood pressure up. If it's a neuromonitoring issue, let them check their leads, make sure nothing moved, something happened, right? The only things that we can really do are wait, just give it some time, get the maps up, give them some steroids, and in the absolute worst case scenario where it really is like something bad happened, it's just to decompress, just wide decompression, open up widely, take any pressure off the spinal cord whatsoever. These are best bets. Now there's been a lot of literature looking at what to do. Okay, so many different papers I went through. A lot of a lot of it is there's a lot of it kind of expert opinion and guidelines. There's really no level one evidence. A lot of it is institutional based. Like if you work at, let's say, Mount Sinai, or you work at Cleveland Clinic, they have a spinal cord injury protocol. Like, okay, if something happens during surgery, this is what we do. Everybody does this, right? But a lot of that is just based on level three evidence. There's really no level one evidence, right? So the only things you can really do are get the maps up, get them above 80. That's really probably the best thing you can do. It's the only thing that's been shown to potentially alter outcomes in a positive way after a true spinal cord injury, right? So get the maps up, maybe give some Dex, give some steroids, right? Get them to get anesthesia to optimize the patient, get the neuromonitoring techs to optimize the patient, make sure that something didn't migrate, something didn't, weird happened. And then in the absolute worst case scenario, if it truly is, just do a wide decompression. You can always you'll never go wrong by just really decompressing the spinal cord widely, like where stuff went in. Now they did mention about using in this paper they mentioned about using the methylprednisolone protocol, the like the traumatic spinal cord injury protocol, the Bracken protocol. But that has not been really, that's a little bit controversial. And whether or not that actually works is yet to be seen. No one's actually done a study showing using the Bracken protocol in an intraoperative setting to see what the outcomes would be. We typically just use dexamethasone. I don't really know if that helps, but it's just something in addition to getting the maps up that can be the best thing that we can do. All right. I'm just curious, Mike, that you're here. Is there like any protocol where you're at, or what's your kind of your go-to for these kind of cases when something goes wrong, you know? All right, maybe Mike stepped away for a little bit. Okay, so the other one is uh, one of the absolute nightmares of any surgeon. So you have a patient who is very has a very large BMI of 62, who presented with acute spinal cord injury. Actually, not really myelopathy. It was more of a cervical spinal cord injury, almost a central cord type syndrome. They were almost quadriparetic when they presented. The decision was made to do a 2, 3, 3, 4, 4, 5, 5, 6 ACDF. Okay. Now, you can imagine this is like, as surgeons, and we've all seen patients like this, let me put it this way, right? Where you literally cannot, due to the body habitus, due to the shoulders, due to the neck, it is, no matter how much you pull down and tape down the shoulders, you really, it is very difficult to see past like C3. And this was like with maximal, we're afraid of, you're basically afraid of like uh pulling dislocating the patient's shoulders, right? Now there are tricks. What you can do is take the fluoro and bring it to about 30 degrees. And you can see a little bit better that way, especially for some patient who's really quite large. But in a true lateral, it can be very difficult to see past the shoulders. You can try to increase um, the milliamps and try to kind of burn through the shoulders, but it can be very difficult. And once you're like during surgery itself, I mean, it can be all washed out. You don't really even know what you're looking at, what's going on, right? This kind of this was the X-ray during surgery. You can see that where's like even C2. I guess is C2 over here. You can kind of see it a little bit. Very hard to see, right? C2 maybe 3, 4, 5. I can't even tell what that is, right? It's not really an adequate X-ray. And I would argue that you should not, um, there should be a very clear, very obvious pre, let's say pre-surgical X-ray before you begin the work, right? Before you actually do the discectomy and interbody fusion, before you do anything, there should be some sort of imaging that clearly designates and delineates what level you're at, right? And if you can't do that, and let's say bring in a O arm or bring in a C arm, get some sort of other imaging. And if you can't do that, then strongly consider just abandoning the case, right? Because like you don't want to be in a situation where you're not exactly sure what level you're operating on, because once you've done the surgery and once you this instrumentation is, it's over, right? So what ended up happening here? This ended up being a C6-7 ACDF, not a C5-6 ACDF. And you can imagine this was not a good situation, right? So wrong level spine surgeries, these are reportable events, meaning like this is like a never event in our OR systems. If something like this happens, this is reported on every level to the hospital administration, to the state, to national reporting agencies. They all learn about this because these are like horrible things. What I found was interesting was that they did this anonymous survey in one of these papers, and almost half of the surgeons, a little bit less, but almost half, 50% of the surgeons had one wrong level spine surgery during their career. When I was in residency and fellowship, I couldn't believe it. I'm like, how is that possible? How can you get a wrong level spine surgery, right? Now that I'm attending, I can see how truly easy it can be. I mean, it can be so easy to get a wrong level spine surgery. It's unbelievable. Um, uh, it some things that come to mind are like patients who have some sort of weird anatomy. They have a sacralized L5 or a lumbralized S1, something like that. Um, or uh, your team booked the case wrong. It was, you saw the patient 4 or 5 months ago, and on the MRI, it was, let's say, an L4-5 disc herniation. You booked it as that, and then your office booked as L3-4 discectomy. So you see it, oh, L3-4 discectomy. You get in there and wait a second, let's check the MRI, right? So the importance of, the importance of checking your always look at imaging before you do a case. I can't stress that enough. It's so important. Sometimes we get a little lazy and it can you have a lot of cases and it can be difficult to always check it out. Okay, so C5-6 ACDF. All right, fine, fine. Let's just get it done, right? But you always have to check. It's so important. Um, uh, Patients who have like missing a rib or something, and you're counting. It can be very, very tricky. It can be very, very tricky. But I agree. I think the true incidence is likely underreported. Um, if it does happen during surgery, you did L3-4, so you did L3-4 and L4-5 or something. I don't know. Um, the main things are really, I'd say, are you have where this can really be an issue is a large body habitus patient where you can't get a good X-ray. It's all washed out, crappy C-arm X-ray. We don't see anything. Um, you you don't have a good X-ray before you begin your work, meaning like you may get like you know, let's say for example, you're doing an ACDF, right? And you put a clamp on what you think, you should say you're doing a 4-5 ACDF. You put a clamp on what you think is 4-5, you get an X-ray, and you're actually at 5-6. Okay, so let's take the clamp off, let's go up one level, right? And then just keep going, right? But you don't actually get an X-ray to confirm that you're at C4-5. That was an issue as well. That became an issue in one of our hospitals. The patient ended up getting a different level ACDF. They missed C4-5. They ended up at C3-4 somehow, right? So these are all things. So what we have actually done at Northwell is we've protocolized the spinal localization for every surgical procedure, ACDF, kyphoplasty, um, lumbar laminectomy, fusions, what have you. It's now protocolized. We had that also at Cleveland Clinic where I did my fellowship. Um, it was all protocolized there. Like there was a very specific protocol that had to be followed before with spinal localization prior to beginning the case. At the Cleveland Clinic, it was very, very, very um, strict, and you can get in a lot of trouble if you didn't do the protocol they had established over there. So it's what I found, and I thought this was very interesting. It's so much more prevalent than we think. And now that I've been in my career for several years, I can see how it can easily happen. It's not like I used to think like I was bewildered how this could possibly happen, but I can so easily see how this could potentially happen to a surgeon, very well-meaning surgeon, even with very, very strict attention to detail, things happen. It's usually just a matter of just having a checklist in your mind of things that need to be done before you actually begin the case. So the vast majority of these were in the lumbar region, which I believe, and followed by the cervical. Thoracic can be very tricky too. What if you have like a T5-6 lesion? It can be hard to localize there. Um, Many times, let's say you're doing a kyphoplasty, right? And let's say it's like a mid-thoracic compression fracture. Maybe it's very subtle. Maybe it's a very subtle, subtle, subtle finding. It's just like an end plate fracture, right? When you put that patient prone and they're not weight bearing anymore, you may not even see it anymore. It may look completely normal, right? And you're like, oh wait, which level is this? And it can be very tricky. It can be very tricky. Sometimes the MRI is wrong. Like the report is wrong. They call it a T7 fracture. It's actually a T8 fracture. Um, because they had some weird nomenclature that you're not using. You know what I mean? Or you would call it C45. I'm sorry, it's L45, but they call it L5S1, right? There's all little things you need to pay attention to. It can be very, 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 very tricky, and the responsibility and the burden of that lays 100% on the surgeon. I'm wondering if maybe let's just actually hold on. I can't see the chat room here. Uh, Wait, sorry. Um, Sorry, guys. One, two. There we go. Um, Anyone have any questions or anyone want to have any comments? I want to kind of take 1 second to mention that. I'm curious if anyone has any at their hospitals have an institutional protocol. If you want to go ahead and put it in the chat room, I'd like to see that. We have just developed one at my hospital now. The one we had at the Cleveland Clinic was for any spine case, uh, you would have to get an intra-op X-ray with a clamp or a needle or something on the level of interest. They would take an X-ray. A radiologist would immediately read that within like 2 minutes or something, call into the room, and then the attending speaks with the radiologist. You say, I think, we're at L45. Yes, we're at L45. Okay, let's keep going. And that had to be for every single case. Um, uh, it's not as that I thought that was very, very strict. I mean, they didn't, that was, it can be challenging. Sometimes you can't do anything. You're waiting for the radiologist to call you back, especially at a weird hour if you have an overnight case. Oh, good luck, good luck with that. Um, at Northwell, we have very specific protocols for every single type of case. It's not as restrictive, it's not strict as Cleveland Clinic, but sometimes even with the strictest protocols, things happen. Things slip through the cracks. I don't see any comments there, so I'm just going to keep going. So what I like to do is for the cervical spine, before I begin anything, right, I basically like to get two. I like to get one with a little small mosquito or clamp on the disc space, right? Once that's the case, I finish the exposure, I undermine the longest, place my retractors, and put the cast bar pins in, and then I get one X-ray with the cast bar pins in to make sure I'm really at the right level, and then I begin the case. And then my next X-rays will be my final X-rays typically. For posterior, I typically do either I put a spinous process clamp on C2, or I'll put like a Penfield 4 in the facet joint. I find that one tends to work quite well. Um, Localization can also be a problem for if you're doing a posterior cervical foraminotomy, especially around C7T1. It can be a little bit tricky if they have a cervical rib or something weird. It can be hard to localize for that one. Is a posterior cervical foraminotomy. I found that's actually a very hard case to localize for. For thoracic spine, I just count from the top or count from the bottom. I find it's easier to typically count from the top for thoracic spine cases. And in lumbar spine cases, I usually put a Penfield 4 at the pars, just slightly under the pedicle, or I put it underneath the lamina, so it points at a disc space. And that's usually my go-to. I find the spinous process clamps are not great. Spinous processes have all kinds of variants and can be all, different lengths and sizes, and they're not very accurate, I feel like. There are kind of expert consensuses and guidelines on what we should do for intraoperative localization. There's tons of literature about this. I'm not going to really go through much into this, but there's tons of literature about what they think is probably the best um, set of clinical decision rules to make before operating. Also, in the absolute worst case scenario, you can always just take a picture of the X-rays, text it to one of your surgeon buddies, and have them, confirm the read. Now, if that ever happens, there are obviously a lot of ramifications for this. One of the ones that we obviously worry about, not just the clinical ramifications, the patient. Another thing, very interesting thing actually. The vast majority of these wrong level spine surgeries were found like way later. Like patient was discharged from the hospital, comes back in. I don't really feel much different, right? Okay, let's just wait, get a new MRI. Oh, disc is still there, or the C4, the level was wrong, on a, let's say, ACDF or TLIF, and that's where it's like a disaster. So uh, if the wrong level surgery occurs, you should still finish the surgery, right? As in, if you meant to do a C4-5 ACF and you did a C5-6, you should still do that C4-5 ACF, complete the case, right? But obviously there are some medical legal ramifications, and one of the best things you can always do is maintain a strong patient-doctor relationship. The patient's going to feel scared. They're going to be angry. They're going to feel like what happened, confused, right? The best thing you can do is just be there with them, support them, walk them through them, and be completely 100% transparent and honest about what happened and what you're going to do with them. In many cases, once the planned surgery has been done, it's not, unless there's some absolute catastrophe that occurred, um, most of the time the patients will be okay, again, unless something really, really bad happened. Um, but the most important thing is to maintain that transparency and honesty with the patient if something happens. I have a question here. Let me just see. What is the most effective preoperative strategies currently recommended for assessing a patient's risk of spinal cord injury during complex spinal surgeries? And how have recent advancement improved these risk assessments? That's a great question. So, there are there's very nice literature on this, on risk of spinal cord injury in patients who are undergoing spinal deformity surgery and patients who are going cervical spinal cord surgery around the cervical spine. Um, the main risk factors and there are different risk factors for both, right? In general, for cervical spine surgery, the main risk factors are, as you can imagine, patient with large, very, very going posterior, and a patient with large body habitus, patients who have OPLL going anterior on those patients, patients who have a disc to lamina measurement. If you measure let's say the disc space to the lamina, and that measurement is less than 4 millimeters, that's a very high risk of spinal cord injury. Um, uh, I don't think there's anything comparing en bloc versus kind of a piecemeal laminectomy, but I would imagine that doing it with kind of a piecemeal approach can potentially increase the risk of spinal cord injury. I don't know if that for sure. I'm just saying that anecdotally. For adult spinal deformity, the risk is just the more severe the curve, ankylosing spondylitis, obesity, patients who have excessive blood loss during the surgery. Um, these are all risks of basically spinal cord ischemia and subsequently trying to overcorrect the patient without mobilizing the spine enough. These are all risks of spinal cord injury. And the more levels that you fuse, obviously more risk. Patient with dysplastic pedicles, the more levels that you fuse, there's more of a risk of something going wrong. All right. So finishing a little early today. I just went through 3 kind of cases. Hopefully you never see any of these ever in your lifetime or ever in your practice. But it's always good to keep in the back of your mind what could happen in the case of these catastrophes, and just have a plan. It's always good to have some sort of a plan, no matter how bad things are. Any questions? Anything that people want to ask me or just want to discuss? We have a little bit of time. If not, we can always end early. That's okay. All right. So if that's the case, no questions. We can end a little bit early tonight. It's a-okay. I don't know if any of you are going to be at uh uh conference in Houston this week, but it'll be great to hang out. So hopefully we can see you all there. So anyway, hope you all enjoy the rest of your week, enjoy the rest of your night, and have a great night. Hope to see you next week at Virtual Global Spine.